Welcome back to The Exam Room, a podcast where we dive deep into the world of value-based care, patient-centered healthcare, and improving health outcomes with your host, Dr. Rhiannon Winsor. Dr. Winsor is a certified surgical technologist, healthcare educator, and the manager of training at VB Care Network. With almost 30 years of experience in healthcare and instructional design, she's spent her career helping clinicians and care teams optimize patient outcomes. How do you make innovation stick in healthcare? In this episode of the Exam Room podcast, Dr. Rhiannon Winsor welcomes back Christian Milaster to unpack the innovation adoption maturity model and why FQHCS need more than good ideas to drive lasting change. From aligning workflows and clinician engagement to redefining bedside manner for the digital age, this episode is a blueprint for building a resilient, forward-thinking care environment.
Talk a little bit about the innovation adoption maturity model.
When you go into a mall and that you've never been to and you're looking for a shop, what's the first thing you do? You go to the map and then you find the store, but then you still don't know where to go because what you're looking for is the red dot that tells you you are here.
Yes.
So that is one problem I was trying to solve for is to give people a tool to say you are here, and then to say, and here's where you want to go, and here is how you get there. The other underlying principle behind a capability maturity model, over the course of my career, I've built out 4 different capability maturities, starting in project management, requirements engineering, telehealth, and now innovation adoption. Is that there's I think we have 12 different dimensions or 12 different characteristics that are underlying our maturity model. How well do you do innovation scanning? How do you have an innovation strategy? How well are you doing project management? How well is your communication? How good is your clinician engagement? So all these different elements that feed into your innovation maturity. And so what an assessment then does, it figures out where are you on the spectrum of the lowest maturity level to the highest maturity level. And then the idea is that all of these 12 dimensions need to be at the same level in order to really accelerate growth. If you don't have your clinicians engaged, you cannot just invest in project management to really have great project management. They all go hand in hand. They're all interconnected with each other. And so that is the idea. The idea is to assess where are we at. Let's get everybody, all the dimensions, all the capabilities and skill sets and tools and kind of at the same level. And then we can go 2, 3 levels up and really leverage innovation strategically to achieve our strategic objectives. And so that is kind of the idea behind the capability maturity model. You are here, here's where you want to go. And here are all the 12 different things that need to work together in order to get us there. It's the approach that we need to do process design well, we need to do project management well, we need to have leaders involved, we have clinicians involved. And so really looking across the 12 different dimensions, is all these elements need to be together at the same maturity model because everything has to work in lockstep. Because if you're just accelerating one thing, you can have the most brilliant innovation strategy that you can imagine of that's really mature. But if you don't have any execution or adoption methodology, then that will not do anything. It'll just be frustrating. It's like good health. We need to have good nutrition. We need to have regular exercise. We need to have good sleep. And we need to take care of our mental health, right? So those 4. You cannot just simply ignore your mental health and your depression or your bad relationship and just dive yourself into exercising. That alone will not suffice, right? You have to address the mental challenges as well. You cannot just exercise really, really well, but then still go to McDonald's after each visit to the gym. I'm a systems engineer from my thinking, so I always look at the whole system and how the elements are interconnected and how they all need to kind of be at the same level so I can quickly jump to the next level.
There has to be that culture that you talked about before. You know, in healthcare, we seem to be pretty change adverse for how much, change is coming at us. How do we shift our mindset to be more innovative, thinkers or early adopters of this out-of-the-box thinking?
Starts with the principle of what's in it for me. For an example, an FQHC wanted to roll out video visits, and everybody was on board, but there was one laggard who said, no, I'm not doing it, right? I've practiced medicine for 35 years. I've tried it during COVID. It didn't work. I had to do it on the phone, and my patients don't want it. That was his nice excuse. But then a few months later, he actually bought a lake house. So he approached the leadership team and said, hey, could I do telehealth like on Fridays and maybe on Mondays? Right? I don't have to come in. I can just do it from a lake house. So suddenly he discovered something that was in it for him. So suddenly he had a motivation to do something. It's change management, change leadership. And so you really need to figure out what is the lever, how can you enroll them. One of the change management models that I use is the ADKAR model, which stands for raising awareness, creating the desire, building knowledge and ability, and then reinforcement. ADKRR was developed by the Prosser Institute. Mayo adopted it 25 years ago and had training classes on it where I first came across it. And so it's that awareness and desire, right? That is the hinge. And that's what you're talking about is if you cannot create the desire in people to change, then it's going to be close to impossible. Humans are very, very creative on finding ways to avoid change. The way we solve that, for example, in telehealth is what I'm realizing, and having actually worked with a lot of FKHCs, is that clinicians they're not really opposed to telehealth, but they have what I call post-traumatic stress disorder from COVID, where they were handed a webcam and a Zoom license and say, go do telehealth, and it didn't work because nobody told them about the processes and nobody prepared the patients either. So it's really about clinicians, especially, are being trained in medical school, from my perspective, to be confident, to always have an answer, to not let on that they're concerned or they don't know what they're doing, because they need to really instill confidence into the patients. So they are very comfortable in the exam room, and they spend many, many hours being trained on how to improve their bedside manners, on how to have a conversation, how to build rapport, and how to really build that relationship so that the patient will trust you with the medications you prescribe, or when you tell them that they need to eat better and sleep better. With telehealth, they were fish out of water. They were suddenly in an environment where they really did not know how everything works. And they were afraid the technology is going to break. And so clinicians were not confident. And so what we've developed over the years here and perfected is a 4 or 5 way approach of really training them on making sure the technology is easy to use, the workflows are really there, and then training them on the website manner. How can you make the lens be your friend, right? How do you actually use the camera to make connections with the patient? And then also, how can you, especially in primary care, how can you develop virtual exams? How can you walk a patient through a self-exam and then document it? And so with this whole skill set, which takes like probably 3 sessions of 30 minutes to train them, now they have all the knowledge and they can relate it to their existing expertise. And now that takes away the fear of failing, because I mean, humans don't like to look stupid, but especially clinicians don't like to fail in front of patients because it's not conducive to care delivery. And so this is what I mean, finding out what is stopping them. It's not the lack of awareness, but it's that knowledge and ability that is missing. And so, for any change, for any innovation adoption, you got to go through the list of stakeholders and you got to ask yourself, where can I find the angle to make it worthwhile? And sometimes it's just, I'm the boss, you're an employee, this is how we're going to do it. Sometimes you have to play that card, but usually that does not last very long. But then people have a choice to leave, because if it's important for the organization to do it, the short-term pain of maybe losing a clinician over that or losing a staff member over that, if you're confident and have done the research that this innovation is really better for the organization in the long term.
I really wanted to hear you talk a little bit more about website manner and what that means and how our FQHCs can maybe, use that.
So website manners is about taking your bedside manners and putting them into the virtual world, right? It's how to be really powerful and engaging, creating an engaging patient-clinician conversation in a virtual video visit. And the idea is to just focus on certain elements. So one is, first of all, to actually look into the camera, right? Because that establishes a direct eye contact and it makes you feel like the clinician is looking at it. Now, it's very disconcerting if you ever tried that, looking into that lens, because your natural tendency is actually to look down, to look at the people and what they're doing. But with some practice, and we recommend you do this the first 30 seconds in the visit, you do it, and then naturally you're going to gravitate to your normal habit again. So that's one aspect. It's such a small trick, and it does wonders. And then when you emphasize, you want to emphasize a point, again, you look into the lens, maybe you lean forward, you use your hands, right? You use your body language to still convey what you would do in an in-person environment, right? In in-person environment, the clinician would lean in, right? They would swivel their chair, they would move away from the computer where they've been typing, and then they would get closer to the patient, they would lower the voice, they would talk small and said, look, Brianna, it's really important that we follow through with this, because otherwise, right, you will end up in the ER again, and I don't want this for you, and I know you don't want this for you and your children, right? And so you bring in this empathy still in there by doing that. So that is one key aspect. The other one is just also just acknowledging how new this is, especially for patients who are doing that the first time. Like if you have a different computer where you're typing in your notes, you're saying, okay, when I'm looking over here, right, I'm not playing solitaire, and I'm looking at your medical record. So like you insert humor if that is part of your personality. Yeah, and then you had like the 7-minute visit, and you said, hey, isn't it great that you didn't have to drive in here and find parking and sit in the waiting room? So I'm really glad that you took me up on the offer to do a video visit today, because I was able to. Any questions from me, anything else you need, right? So it's really empowering the clinicians to be comfortable with that technology, and then to extend that knowledge onto the patients as well, to have the patient feel welcome. And you say, oh, I see in your background, right, you've got some diplomas there on the walls. Tell me about those, right? You're having a home office, right? So you connect with them on a personal level, and you take into consideration kind of what you're seeing there, and what they're doing. So in order to really have a great experience, we need to have website manners training. We need to really increase the comfort level of the clinicians to use virtual visits in the right way, which then also includes virtual exams, right? And we have our chief clinical officer, who's formerly of the Cleveland Clinic, the medical director of Virtual Express Care, walk our clients, clinicians, through the process of how to do a virtual exam and how to properly document it in the medical record. And he said, it's amazing what you can actually do. And the other thing that I always tell clinicians is like, yes, you make a diagnosis just based on the history. You confirm it maybe with a visual or with a physical exam, and then you order tests to confirm. Right? You still have a radiological test, you still have a blood test, so you kind of know, but you still confirm. So in healthcare, we never. And then as it's really straightforward, like a rash or a UTI or something like that. But even then, we still double check, and we still make sure we have things in place. And that's the same for virtual care, for video visits. We always have some other measures to make sure that we can confirm our diagnosis.
I'm guessing it's just human nature with the repetition of things that we get to a point where we're kind of on autopilot a little bit, like I've driven a car so many times, really don't have to think about how to do it. I just kind of get in and my body automatically does what it's supposed to do. I used to caution my students of not getting into that habit of it's the hysterectomy in room 4, it's the ORIF in room 2. Like, that's a human, that's a mom, a brother, a sister, a dad, friend, and not to get so complacent. And I think it's always a good reminder for all of us to not just to have awareness, and be present and not just go through the box checking, but to actually be present for our patients, have empathy for our patients. Remember, this could be our own mother, brother, sister, friend, and then that's going to increase connectivity. That's going to increase patient engagement, hopefully, because they do get the sense that we care. Because we do care, right? It's not that we don't care.
But therein lies also the challenge, right? And I think one of the reasons, I mean, you see that on the TV shows done in the ER, right, where the patients are being categorized by the problems that they're coming in for. And that's the flip side of the coin. You cannot get too emotionally attached and involved in these cases either, because otherwise you take it home every day, right? So yes, we need to be caring without becoming involved in it, and that's hard to balance, and that's what clinicians have to deal with right? They have patient panels of 1,500 patients, and they probably could tell you about any one of them, but also they need to keep their own healthy emotional distance. And so
thank you, Christian, for such an insightful and energizing conversation. From shifting mindsets to scaling smart innovations, you've given us a powerful lens on how FQHCs can not only keep up with change, but lead it. For our listeners, if today's episode sparked an idea or gave you a new perspective, share it with your team. And let's keep building a future where innovation fuels extraordinary care. Until next time, thank you for joining us in the exam room.
Thank you for joining us in the exam room, where we examine the vital signs of value-based care and diagnose what's shaping the future of healthcare. We hope this conversation was as insightful as your last checkup. A big thank you to our guests for sharing their expertise and prescribing actionable ideas. Stay tuned for more episodes as we probe the topics that matter most in value-based care. Until next time, take care, and thanks for listening to The Exam Room.